Division of Gynecologic Oncology and a member of the National Cancer Institute designated Chow Family Comprehensive Cancer Center. She is board certified to deliver comprehensive medical and surgical care to women with all gynecologic cancers. Dr. Randall's research interests focus on the investigation of new cancer treatments and new imaging techniques. She holds a master's degree in advanced clinical research, serves as a member of the NCI-sponsored NRG Oncology Group Ovarian Cancer and Developmental Therapeutics Committees, and sits on the board of directors for the Gynecologic Oncology Group, the GOG Foundation. Dr. Randall also serves as the Director of Education and Fellowship Director for Gynecologic Oncology at UCI, and is a member of the advisory board for the Queen of Hearts Foundation. And we'll begin just a moment, and I'd like to thank our sponsor for today's webinar, Tesaro, and with that, I'm going to turn it over to Dr. Randall.
Great to be on this webinar, especially because I can do it from my kitchen. So I'm coming to you live from my kitchen. I'm working from home today. It's pouring rain here in Southern California. And I'm going to switch over to my screen. So those are my kids. Let's see, bring up these slides and hide this here. So it's really exciting to come and talk to you today about maintenance treatment. I'll show you some data that shows that there are many women in the US who either aren't being offered maintenance treatment or are electing not to pursue maintenance treatment. And so we'll talk a little bit about what maintenance treatment means. So if you're joining today, I'm assuming that you're probably someone who either has or knows or loves someone who is affected by ovarian cancer, and know that any new treatment options that are available are going to be very important. And so I think that knowledge is definitely power. And so it's very important to me to have this opportunity to talk to you about some options that are out there that you may or may not be aware of. Let's see. So as I was just saying, recent advances in the treatment for ovarian, which also includes fallopian tube and peritoneal cancer, can now offer patients additional treatment options. And one of these is maintenance treatment. So maintenance treatment means treatment that is continued after platinum-based chemotherapy is given. And so if those of you online have had treatment for ovarian cancer, you're very aware of the carboplatin treatment regimens. They're usually given in combination with another medication like Taxol, gemcitabine, or Doxil. And maintenance treatment means after that big, I call it big chemotherapy, after that big chemotherapy is done, something that's much more tolerable to take can be continued to help the cancer stay away. So you get this nice response to your platinum chemotherapy, but you want to keep that going. But most of you know that you can't continue that platinum-based chemotherapy much longer because it is so harsh to the body. And so we need something that the body can tolerate that will offer more time without the cancer spreading or growing. So today we'll talk a little bit about advanced ovarian cancer, a little bit more about what is maintenance treatment, the specific treatment options for maintenance in advanced ovarian cancer, and some thought-provoking questions. Could maintenance treatment be right for you? So about advanced ovarian cancer, if you're on this webinar, you probably know all too well that the vast majority of our patients who are diagnosed with ovarian cancer fall into this 59 plus 20% of this pie where the cancer is already spread into the abdominal area or even into the lymph nodes or into the lung, most oftenly in the form of what we call a pleural effusion, which is fluid on the lung. Very infrequently do we find it in the early curable stages, about 15% of the time. And most of the time when we find it early, we find it by accident. Someone got a CT scan because they thought they had appendicitis and they found a cyst, and it ended up being early stage ovarian cancer. We can also detect it early when we do risk-reducing surgery for our BRCA patients. But most of the time, even in our BRCA patients, we're finding it at a more advanced stage. So when we do diagnose ovarian cancer, the main treatments are a combination of chemotherapy and surgery. So we typically would do surgery first, followed by chemotherapy after surgery, although it's becoming increasingly more common to give chemotherapy first to shrink the tumor and make the surgery much easier for both the surgeon and for the patients. And when we give that chemotherapy, it's a platinum-based chemotherapy, and typically we're using a drug called carboplatin. Sometimes we're using cisplatin. Most of the time we're giving the chemotherapy intravenously. Some protocols call for peritoneal chemotherapy, though this has become less popular in the past few years. So most patients will have a complete response to that initial treatment. And these are the types of responses. So the vast majority will fall into this category where there are no remaining signs or symptoms from cancer. The CA-125 number falls to normal, and this is what we call remission. Sometimes we only get a partial response to treatment. And so for the first treatment, we almost always get a complete response. And then for the second and third and fourth treatments, we'll often get a complete, but more frequently a partial response. Sometimes we can have persistent disease after the chemotherapy is done, meaning it didn't really go away in response to the chemotherapy, or the cancer can even grow despite treatment. And so when this is happening, we're generally thinking that the cancer is resistant to platinum resistant, or treatment resistant. And in these categories, the cancer is still pretty sensitive or responsive to the treatments. So back to the diagnosis at the certain stages of cancer, the more advanced the cancer is at the time of diagnosis, the higher the chance of a reoccurrence of the cancer after treatment. So again, we said that most of our patients will have a complete response, but even when they do, even in the earlier stages, stage 2, and definitely in stage 3, and definitely in stage 4, most of these patients will have a reoccurrence of the cancer. And those of you on this webinar may have already experienced this. Now, it varies widely from patient to patient how long it takes for the cancer to come back. And sometimes the remission from the first treatment can last for several years. So even though it has a high chance of coming back, it doesn't always come back very quickly. It can, but it often will stay away for at least 6 months, if not much longer than that. Once recurrence is diagnosed, we typically can give more chemotherapy. And some women, this picture shows getting treatment a second, a third, a fourth time. It's not uncommon for ovarian cancer patients to get up to 10 to 12 even different lines of treatment. And that's very unusual for any type of solid tumor cancer. Most tumor types have 3 treatment options at a maximum, but ovarian cancer is special in that we can continue to give different types of treatments, and the cancer will typically respond. That's, of course, not always the case, and it's not pleasant to be on treatment, but in contrast to other tumor types, ovarian cancer can respond more than once to different treatments. So once the treatment is finished, and we're talking now about platinum-based treatment in the recurrent setting, we have two options after that treatment is done. We can, kind of watch and wait and observe and see what happens. That's generally every 3 months, getting a CA-125, a physical exam, and a checkup with your doctor, sometimes CT scans, or now we have the option of maintenance treatment. And again, these are for our platinum-sensitive patients who have been on platinum-based treatments. Maintenance is not well established for our platinum-resistant patients, although we're actively studying that for those women. So there are two options for maintenance. They attack the tumor in two different ways. One is called antiangiogenic therapy, and one is called a PARP inhibitor. So let's talk about what those are. And again, maintenance is treatment that follows the treatment for recurrence. So back to our disease timeline, there's a diagnosis and treatment. There's the initial platinum-based chemotherapy that we talked about in the beginning. There's a response to that treatment, and then there's a remission. And following the remission, which we said can last various lengths of time, when and if recurrence happens, and it happens depending on what the stage of the cancer is, as we said, but often frequently, then we give the platinum-based chemotherapy again. And for those women who've had a response to their platinum-based chemotherapy, and it can be a complete response or it can be a partial response, as long as it's some response, then they are candidates to get maintenance treatment. And again, these are the two different options. So these two options, we have drugs that are FDA approved for these two different strategies. For anti-angiogenesis therapy, the drug is called Bevacizumab or Avastin, and it's given, and it's an intravenous infusion every 3 weeks. And there's a quite different option called a PARP inhibitor, and there are 3 PARP inhibitors that are currently approved. So niraparib or Zejula, olaparib or Lynparza, and rucaparib or Rubraca. And these are pills that are taken by mouth either once or twice daily, depending on which drug you're using. So let's go to an overview of the maintenance treatments, how they're given, how they work, what are their side effects, and what are the results of the clinical trials that led to their approval. So anti-angiogenic therapy, we said that was bevacizumab that's given intravenously. It can take 30 to 90 minutes to give the bevacizumab infusion. And it's typically given with the platinum-based chemotherapy. And after that chemotherapy is done, then the bevacizumab is continued as a maintenance treatment. And what bevacizumab does is attack the blood vessels that feed the tumor. So blood vessels take nutrients to tumors that allow it to grow, but bevacizumab attacks these small blood vessels that feed, and you can imagine a tumor being right here. So bevacizumab attacks these blood vessels and cause them to shrivel away. And so if you have a tumor here, the tumor will basically be starved by the loss of blood supply and the loss of nutrients that happens as a result of giving bevacizumab. The downside is that these vascular changes can happen to the normal tissues, and so this can cause serious problems with bleeding. It can cause problems with wounds that don't heal. And there's a rare but serious complication that can happen with bevacizumab called a gastrointestinal perforation, which is a very fancy term for having a hole that forms spontaneously in the stomach or more frequently in the intestine. And sometimes that can be something that heals on its own after the bevacizumab is stopped, but that can be a catastrophic complication of bevacizumab. And so we're all very cautious of that potential problem when we give bevacizumab. So 2 clinical trials were performed that studied the outcome of women who were treated with bevacizumab. And patients that were studied were women with recurrent cancer who were sensitive to platinum. And it was mostly ovarian cancer, but it could also include fallopian tube or primary peritoneal cancer. And in these 2 studies, women were given platinum-based chemotherapy with or without the bevacizumab for 6 to 10 treatment cycles. And after those treatment cycles were finished, the patients continued to receive the bevacizumab as a maintenance or no bevacizumab, the watch and wait approach. And this was randomly selected at the beginning of the study. So the doctors or the patients could not choose which treatment arm they would be a part of. And at the time, we didn't know which one was better. And that's why we were doing these 2 clinical trials. So the results showed that chemotherapy and watch and wait had a median progression-free survival time of 8 to 10 months. So what that meant was from the time that chemotherapy was started, from the time that the cancer reoccurred, you generally got 8 to 10 months, and that included the time of the chemotherapy. So in essence, not long after the chemotherapy was stopped, the cancer would grow back. In the arms where chemotherapy plus bevacizumab followed by bevacizumab maintenance were given, so if the bevacizumab were continued past the time that the chemotherapy was finished, that extended that time from 8 to 10 months to 12 to 14 months. So women on this study lived 3 to 4 months longer without progression. So this was not their lifespan, this was the time of their remission. So their remission was 3 to 4 months longer with the addition of the bevacizumab. And I'll go back 1 second and I will just point out that we gained 3 to 4 months of remission time, but it is at the expense of those side effects that we discussed with bevacizumab. So PARP inhibitors are approved for maintenance treatment of recurrent ovarian cancer. And again, there are 3 drugs that are approved. They're all taken by mouth and can be taken with or without food. They're different treatment regimens based on the pill. Niraparib is generally given as 2 or 3 100 milligram capsules. It's given once a day. Olaparib is given as 2 150 milligram tablets, and it's given twice daily. Rucaparib is typically given as 2 300 milligram tablets twice daily. Now, all of these can have their dosage reduced if they cause untoward side effects, and we think that they're still mostly have the same effect on the cancer, even if you reduce the dose, but sometimes we need to reduce the amount that we're giving to help control some of the side effects of the treatment. Those side effects include low blood counts, so commonly anemia or low red blood cell count that might require iron treatment or blood transfusion. The infection fighting cells or neutropenia can happen. We don't generally use the same drugs like Neupogen or Neulasta that we use with chemotherapy. We would typically just give a break or reduce the dose of the PARP inhibitor treatment to help with the neutropenia. And the blood clotting cells or the platelets can also be affected and are also managed by reducing the dose of the PARP inhibitor drug. The very common side effect of these PARP inhibitors are gastrointestinal issues, most commonly nausea and sometimes vomiting, and then less frequently diarrhea. The nausea can be controlled with medications, but I do find that a lot of my patients have trouble controlling some of the nausea with PARP inhibitors, with the usual chemotherapy drugs like Zofran or Phenergan. Sometimes we manage the nausea also with a break from the PARP inhibitor or reducing the dose. So the way PARP inhibitors work is a little bit complicated. I'll try to do my best to explain how it works, and I hope that you can follow along with me. Cancer cells can look and act like normal, healthy cells. So if you see, this is a healthy cell and this is a cancer cell. And the DNA in the cells in the body can be damaged spontaneously or by a variety of agents, including radiation or chemotherapy. So when DNA damage is not fixed, the damage accumulates and leads to the death of the cell. PARP is a protein that repairs damaged DNA, and fixing the damaged DNA helps the cell continue to function. PARP inhibitors block PARP from repairing the DNA. And so what happens is all of the DNA damage, instead of being fixed, will continue to accumulate, so that you'll have many, many problems with the DNA in the cell. And this affects cancer cells at a faster rate than it does the healthy cell. So here you can see many more hits of damage. These squiggly lines here are indicating an area of DNA damage. And there are many, many areas of DNA damage in the cancer cell, much more so than the healthy cell. And if you have a cell that has a BRCA mutation, you can double the number of hits. So BRCA mutated cells are very sensitive to this PARP inhibitor treatment. But all ovarian cancer cells that are platinum sensitive are sensitive to PARP inhibitor treatment. The PARP inhibitor drug further prevents the cell from fixing all this damage. And so what happens is the cell dies. And we have a fancy term for that in science. It's called synthetic lethality, meaning the cell's already in trouble, but by blocking the PARP inhibitor, which is its rescue mechanism, it leads to more trouble and then death of the cell. And so it's sort of going in through the side door or the back door instead of the front door to kill the cancer. It's a sneak attack on the cancer. So we knew that in the laboratory that that's how these PARP inhibitor treatments worked, and so they were a high priority to move into clinical trials. And the clinical trials for PARP inhibitors have been going on for the past 10 years. And they've now been well studied as a maintenance treatment for recurrent ovarian cancer in response to the last platinum-based chemotherapy. So again, platinum-sensitive ovarian cancer in women who've had a complete or partial response to their last treatment. To date, there have been 3 large phase 3 trials. So those are the randomized trials, placebo-controlled. That's the best evidence that you can get that something is helpful for women with ovarian cancer. And patients in these trials either receive the maintenance PARP inhibitor treatment or they receive that placebo sugar pill. And like watching and waiting, placebo does not treat the cancer. Now the women did not get, they did get chemotherapy, so they didn't get a complete placebo for during the clinical trial. And that's a common fear of going on a clinical trial, is that you'll get a placebo and not get treatment. They all got the standard chemotherapy. It was just after chemotherapy, did they get the maintenance treatment or did they just get placebo? So the placebo was only given for maintenance treatment and not for the regular chemotherapy part of the study, and that's important. So these clinical trials tested to see if the PARP inhibitor was able to improve the progression-free survival, or that remission time that we looked at with bevacizumab, compared to the watching and waiting approach. So more than 1,600 women with recurrent ovarian, fallopian tube, or peritoneal cancer that had been treated with at least 2 rounds of platinum-based chemotherapy, so that was that initial diagnosis, and at least 1 recurrence, but they could have had 2 or more recurrences and still getting platinum, and again had a partial or complete response to that most recent platinum-based treatment when went on these clinical trials. So some of the women had a mutation in the BRCA gene, and some of them did not. So there's a misconception that PARP inhibitors are only for women who have BRCA mutations, and that's not necessarily true. Some in these maintenance trials, there were many women on these studies that responded to the PARP inhibitor that did not have a BRCA mutation. So the PARP inhibitors offered more time without cancer spreading or growing than the watch and wait approach. And we looked at what that looked like for bevacizumab, but for the PARP inhibitors, women lived 7 to 16 months longer in remission on the PARP inhibitor than they did without the placebo or the watch and wait approach. Now, counting these months, it's different for the PARP inhibitor trials than it was for the bevacizumab trials. So I told you before that the remission time for bevacizumab included the chemotherapy time. The remission time for PARP trials does not include the chemotherapy time. So in the PARP inhibitor trials, they started counting remission time after the chemotherapy was done. So if you can't really compare the PARP trials directly to the bevacizumab trials. It's a little bit more complicated than, it's like apples and oranges instead of apples and apples. But if you compare the PARP inhibitor to the watch and wait or the placebo group, the remission time was 7 to 16 months longer with the PARP inhibitor. And that is in women with BRCA positive cancer. In women with BRCA negative cancer, there was still an improvement, but it wasn't as long as those women with the BRCA mutated or BRCA positive cancer. So in the BRCA negative groups, that time extended in remission was on average 2 to 5 months longer. So a little more similar to what we saw with bevacizumab, but with a different route of administration, an oral drug, and with a different side effect profile. So in summary, most patients with advanced ovarian cancer will see their cancer come back after treatment. Maintenance treatment is given after you complete platinum-based chemotherapy and if you have a partial or complete response to your most recent chemotherapy treatment. The goal of maintenance treatment is to increase the time during which the cancer does not grow or come back. And the current options for maintenance treatment in patients with recurrent ovarian cancer are the anti-angiogenic agent bevacizumab, or one of 3 PARP inhibitors, niraparib, olaparib, and rucaparib. So, could maintenance be right for you? For women who have had a response to their platinum-based chemotherapy, you would be eligible. Now, despite all of these advances in bevacizumab and the PARP inhibitors, almost 60% of patients with recurrent cancer do not get maintenance treatment. And this is based on data from insurance companies looking at what women are getting treated with after their chemotherapy is completed. And so about 40% of them are getting maintenance treatment and 60% of them are in that watch and wait or in that placebo group. So there are really 3 questions to consider about maintenance treatment. We've shown that in the clinical trials that maintenance treatment was effective. It's clearly effective for the women, especially PARP inhibitors for women with BRCA mutations, but are the side effects manageable? And does this treatment fit into your goals of care and to your quality of life? We looked at quality of life in these studies, and on average, quality of life was not diminished or affected in a bad way by being on maintenance treatment, but that doesn't mean, you know, for an individual person that it's the right treatment. So it's really a discussion that you should have with your doctor about, you know, what does it mean to be on maintenance treatment? How am I going to feel? And how do I have to change my life to continue the treatment? And these are those questions. So if you feel like you might be a candidate for the maintenance treatment, some questions to ask your doctor could be, can we talk more about my treatment options and what we think will work best for me? Could you tell me when maintenance would be a good option for me? And if I start maintenance treatment, what support resources would be available to help me get started and stay on track? So again, I'm very happy to have the chance to speak with you all today to talk to you about these options. And I'm hoping that we can improve the number of women on maintenance, or at least start to understand why women are not getting maintenance treatment. And I thank you very much for your attention. And I think
Dr.
we have
Randall,
questions.
Yeah, I wanted to thank you for going through all of this with us today. Really appreciated the last few slides about how to evaluate this option if you're a patient. But in going through, there are a couple of questions, you know, that we've heard from our constituents and kind of brought up during your presentation. So the one question is, you talked about when taking PARP inhibitors for maintenance, and, you know, sometimes managing side effects by doing dose reductions. When you do the dose reductions, does that change the effectiveness of the treatment?
You know, we don't think that it does. And we have some data showing that it does not reduce the effectiveness of the treatment. To know 100% for sure, you would have to do like a clinical trial where you gave people, you know, several different doses and you followed them over time to be certain. But we have some preliminary data that's not the total gold standard of data, but it's good data that show that it does not affect the effectiveness. It doesn't have a bad effect on the efficacy of the drug. So we think that it's okay. It's certainly better than stopping the drug because you didn't tolerate it. So if you stop the drug because you're not tolerating it, instead of dose reducing it, if you just stop it, then you all of a sudden are on in that placebo arm. You're on that watch and wait, in that watch and wait group again. So we think it's better to get some rather than none, if that makes sense.
That does make sense. Thank you. And then the other question, you know, kind of on topic yet off topic. You, in the beginning of your conversation, you mentioned that all of these treatments, of course, were for platinum sensitive. Can you speak to any efforts, any trials, any research that's going on in that platinum resistance arena?
Yes, absolutely. So we know that the Bevacizumab drug is active in the platinum-resistant patients. The drug class that's being actively investigated in platinum-resistant right now is the PARP inhibitors. Immuno-oncology is also, immunotherapy is also a high priority for clinical trials right now, and there are many, many clinical trials in immunotherapy for ovarian cancer that are either happening or that are under development right now. We are starting to look at testing the tumors. So taking a sample of the tumor and looking at, what markers make each individual person's tumor tick, and trying to tailor therapy to those markers. That's called personalized medicine. And we're really moving in that direction, especially for the platinum-resistant patients, because in the platinum-resistant space, the options are so much more limited than they are in the platinum-sensitive arena.
Thank you. And I have one more question, and this goes back to the oral medications, the PARP inhibitors. We have heard anecdotally from people about the cost of these drugs. Can you talk about in your practice what experience you've had with your patients who take these drugs? Have you known of a lot of issues that people have had with getting them covered and co-payments and things like that?
Yeah, I can really speak to that. I think that's probably like one of the biggest, drawbacks of the treatment. I wish it were less expensive. Right now it's not. Eventually, it will be. If you're using it for the reasons for which it's approved, I haven't had difficulty getting coverage for the drug for my patients who have insurance. If we tried to use it off of the FDA approval label, meaning for other reasons besides for what it's approved, we've had trouble getting coverage. If our patients don't have insurance, they've had difficulty with access. Each of these companies have, for all four of the maintenance drugs, have patient assistance programs that can help them access these drugs. They provide financial support. They also have programs that provide nursing support. So like hotlines that even once you have it covered, if you have difficulty with the drug or questions about the drug, the companies offer hotlines in addition to what the doctor's nursing staff can provide. But I have not had a patient not be able to take treatment because of lack of affordability. We've always been able to find a way.
That's good. I'm glad to hear that. Yeah. Well, I want to, we'll wrap up there, but I want to thank you again for this really terrific presentation. I think it was very easy to understand. There's just so much conversation, I think, in the ovarian cancer space right now about these new treatments. And so from the National Ovarian Cancer Coalition, I'm really pleased to be able to offer this education to our community. And I want to let those of you who have tuned in with us today know that we did record this webinar, and you will be able to access it through the NOCC's YouTube channel. So feel free to go back and to listen to parts that you might have missed, or share it with others that you think would want to hear it. So to all of you who did join us today, I want to thank you for your time and wish you all the best from the NOCC. Thanks so much, everyone.
Thank you.
So there's no Q&A.
We're done now.
Okay.
Yes, we're good. All right, thank you so much.